Good evening, everyone. Great pleasure to be here.
Can we dim the lights, please?
Yes, sir. Do it proper. Hello. So, indeed, a great pleasure to be here amongst you all. I have been to this forum maybe 100 or 200 CMEs ago, and that time we had given a talk on TAVR, that is the the endovascular aortic valve replacement. So great pleasure now to be here. We are supposed to be two speakers from DLK, so both the talks were supposed to be complementary. The plan was that first the benefits of bypass surgery would be told, and then I would do a little leg pulling and tell you when bypass surgery is not working. We should consider angioplasty for these. So I have labeled my talk. Put on the screen, please. So my talk is angioplasty after bypass surgery. When, why, and how. All right. So can we have some of these lights down? Maybe these ones? Two of them. All right. So bypass surgery is considered as maybe the final solution for coronary artery disease. And after that, we think that now this is done. There is no further treatment required. Everything looked after. But is that really the case? That's what we are trying to look into. And I think in this scenario of diabetes epidemic, atherosclerotic cardiovascular disease epidemic, younger age of getting CAD, which all happens in our country, it's important to understand what is the scenario after CABG also. So, CABG continues to remain one of the most common surgical procedures, and we know that multiple grafts are usually placed, of which the vein graft continues to be the most used conduit in the patients undergoing CABG, owing to many factors: availability, ease of harvesting. Despite secondary prevention measures, approximately only half of vein grafts are patent at 10 years. 50% of vein grafts have closed down within 10 years. And this loss of grafts keeps on rapidly increasing after 10 years are over. Angioplasty of vein grafts approximately counts for about 6% of all angioplasties, but it is associated with an increased risk of peri-procedural complications, late complications, and increased mortality. So vein grafts deteriorate at a regular rate. Half your vein grafts are closed within 10 years, and there is no easy solution for vein graft angioplasty because although it's a small number, it is associated with a higher risk of peri-procedural, procedural, late complication, and even mortality. What is the history of CABG? Just we'll spend a few minutes, quite interesting. Cardiopulmonary bypass started in 1952. Angiography started in 1958. First CABG done in 1960. And then David Saveston performed the first CABG using an anastomosed vein graft. First NEMA to LAD performed by a Russian surgeon, Vasily Koselov, as early as 1964. Introduction of hyperkalemic cardioplegia, on-pump and off-pump surgery started by 1975, off-pump surgery. Superiority of IHA graft to LAD was realized by 1986. and the octopus stabilizer, which is now the most standard way of stabilizing the coronary artery while placing grafts, introduced in 1996. Minimally invasive direct CABG, total endoscopic Lima anastomosis. This is actually Dr. Ramji's field. But just to show you a timeline of how surgery has evolved since the 1950s till the 2000s. Now, two therapies are clashing over here. One is angioplasty, started in 1975 by Andreas Brunzek, and CABG started in 1964. So these two therapies have been going head to head against each other, and a number of trials have been conducted to understand which is better than the other. Is one better or is the other better? As is expected in a complex scenario, there are no easy answers. So in a trial conducted by, these are the two latest trials, the Noble and the Excel trial. The Noble trial was conducted by surgeons. It showed superiority of surgical outcomes, mainly because there was a increase in stroke rates. In the trial, the Excel trial conducted by interventional cardiologists, both the treatments were superior. But the sum and substance of this is, there is really no difference in death. There is no difference in MI. There is only difference in the need for a repeat procedure if angioplasty is done as compared to CABG. This is why angioplasty is sometimes seen as a course of treatment rather than a standalone treatment itself. And we know that in the time taken for a patient to undergo bypass surgery, the whole morbidity, the whole process and the whole procedure, angioplasty is relatively straightforward, can be done and the patient discharged home within a day or two in most cases. So acceptability of a repeat procedure, if it is there in the patient's mind, then really the two procedures are almost the same. So the sum and substance is like this. Now let's see what the guidelines tell us. We should, because clinical trials, who runs it, who does not run it, there are bodies that have recommended what should be the preferred procedure in a given scenario. So just let's look at this. Recommendations of type of revascularization according to extent of CABG. Without proximal LAD stenosis, angioplasty scores over CABG. With proximal LAD stenosis, both are equal. In two vessel CAD, without proximal, almost same recommendations. So if there is no proximal LAD stenosis, no benefit of CABG. If there is proximal LAD stenosis, both the therapies are equal. More complex, that is left main coronary artery disease, if the complexity of the lesion, which we determine by a score known as syntax score, which looks at whether it's calcified, whether it's totally occluded, whether it is a long lesion, whether it's a bifurcation, the complexity of the disease, if it is low to intermediate, both the therapies have got almost equal recommendations. Two ways generally recommended therapy. When the coronary artery disease is very complex, then CABG scores over angioplasty. So, in many instances, as you see in the guidelines, both the therapies are given equal weightage, except in left main disease with complex coronary artery disease, not amenable to PCI, then CABG is recommended. The other scenario is 3-vessel disease with diabetes. So if you have 3-vessel disease and you have diabetes, surgery scores over angioplasty if there is a high complexity. If there is low complexity with diabetes, both are equal. But if there is intermediate or high complexity with diabetes, surgical revascularization is favored, again from the point of view because Diabetics usually have more diffuse disease and the chances of repeat procedures are much higher. So CABG scores over angioplasty in patients who have got 3 vessel disease with low syntax score, 3 vessel disease with intermediate or high syntax score. So low syntax score, 2B recommendation for angioplasty means that generally should not be preferred. And 3 means that should not be preferred if at all possible. Contraindication can do harm. So diabetics with 3 vessel disease, left main disease with complexity. These are the 2 areas only where bypass surgery scores clearly over angioplasty. So, in spite of great advancements like arterial grafts and off bypass procedure, recurring ischemia may ensue with lesions of the graft. Immediately after bypass surgery, up to 5% of patients might have severe ischemia. Every year, about up to 8% of post-bypass patients get ischemic or become symptomatic. Within a year, 8%, 2 years, 16%. So that's how it goes. The reasons for this are because of this. Either there is native disease progression or there is bypass graft failure. In a study done by the National Database Registry in the US, in post-CABG patients, there was maximum progress in the native vessel disease which was not bypassed, or in which there was bypass graft failure, and this native vessel had to undergo angioplasty. Second commonest was vein graft, third commonest was arterial graft. So you might have progression in the native disease where the lesion was not significant, the surgeon did not think it needed bypass, it was left alone. Or you might have bypass graft failure. These are the 2 causes that can cause patients after bypass to become symptomatic. Early post-operative ischemia, I told you up to 5% of patients might experience severe ischemia in the early post-operative period also. Why does that happen? There is loss of the vein graft due to acute vein thrombosis. Why could that happen? Because of many issues. So, most common cause is loss of the vein graft acutely due to graft thrombosis. Other causes, incomplete surgical vascularization, ink grafts, stenosis at the proximal or distal anastomotic site, focal stenosis distal to the insertion site, inaccessible intramyocardial position of the recipient artery, bypass of the wrong vessel. And we have seen all these things happening in our patients at some time or here. So there are a host of things that can happen that cause your patients to become severely ischemic in the post-operative period alone. Within 1 month and 1 year of bypass, most common causes perianastomotic stenosis or graft occlusion due to intimal hyperplasia of the vein. So early graft failure rates can occur up to 12% of the grafts, and about 1/4 of these patients develop symptoms. 3/4 of the patients whose grafts are closed in the post-op period, their symptoms, either they do not have symptoms or symptoms are not recognized because patients having pain from sternotomy, some this and that. No one realizes that the grafts are closed, but up to 12% of the grafts may close before the patient leaves the hospital. Graft occlusion rates are higher for vein grafts as compared to radial artery or to the internal artery graft. Late onset ischemia, 1 to 3 years after bypass, could be due to new stenosis in grafts and native coronary arteries, both of which can be successfully managed. More than 3 years, new atherosclerosis in the vein graft, which are softer, more friable, more extensive disease. I'll showcase at the end. extensively diseased vein grafts happen remotely after bypass. And these plaques have got thrombus. Once we instrument them, the thrombus goes downstream, plugs the native vessel, it causes slow flow. This is why vein grafts have more complications as compared to native grafts. So you can look at some of these, what we have already discussed. How do we prepare grafts so that there is that they do not close in the perioperative period. And this is how grafts start looking. This is a vein graft. It starts looking a bit ragged in the middle over here. After 5 years, it's extensive diffuse disease and it may be totally occluded. Once there's extensive diffuse disease or there's total occlusion, native vessel angioplasty is preferred over vein graft PCI because getting a successful, sustainable, good result without any complications is harder to do.
Dr. Bhalla, we can conclude?
Yeah. No, there is little time.
A lot of interactions are awaiting you.
Okay. So just give me a few more minutes. So I told you early graft failure, least in the internal mammary grafts and much higher in the vein grafts. So indications for intervention are that post-CABD symptomatic patients not suitable for redo surgery because of several complications, maybe old age, other comorbidities, malignancy. So these patients are eligible, if they are symptomatic, eligible for PCI. Other patients who can undergo PCI, those who have patent arterial graft but occluded vein graft. Factors favoring redo CABG are multivessel disease requiring an arterial graft, severe vein graft disease, poor ventricle availability of arterial graft. So this is the same thing that we have said. And so once there is graft failure, angiography is recommended if the patient has got significant ischemia, either symptomatic or with abnormal biomarkers, large area of risk, any hemodynamic instability. So repeat revascularization is indicated in patients with large ischemia or severe symptoms despite medical therapy in the early graft as well as in disease progression and late graft failure. CABG versus PCI, what are the recommendations? Internal mammary should be the conduit of choice for redo patients in whom it was not used previously. Redo should be considered for patients without a patent, even if the vein graft is occluded, it should be used. And of course for bypass, we will go a little bit quickly now. As Dr. Tulsi said, we'll try to incorporate. So this is the bit technical features of how to assess ischemia using FFR. So we just go through all this. So once we do PCI post CABG of vein graft or arterial graft, there are certain technical things that need to be done to improve outcomes. Using drug-eluting stents, using a basket for embolic protection to prevent distal embolization, use of vasodilator drugs. So if it is a Lima anastomotic site angioplasty, only balloon is okay, we do not need to have stents. So there are several technical features which show us which stents are good. Drug-eluting stents, like in native vessels, are better in vein graft as compared to bare metal stents, up to vein graft of 3.5 or 4 millimeters. Sometimes vein grafts are very large. If they are anything more than 3.5 millimeters, you can use bare metal stents. So I think this is all technical details. I don't think we need to talk about. We can talk about this in the interactions.
Yes.
So again, PCI of internal mammary grafts can be done requiring the usual techniques. Only thing is the internal mammary graft very tortuous. Once you put a wire down, it causes a lot of pseudo lesions or it causes inking of the vein graft. So you need to be aware of that. So we use very soft wires which prevent this do not result in this. So several, and then of course we need to give dual antiplatelet treatment for a longer duration of time. So this can be kind of algorithm how to go about it, and basically it needs to be individualized. And the basic thing is that if a Lima to LAD is not feasible, then you may consider if vein graft or native lesion PCI, provided the vein graft lesion is not too complex and the native artery is not too diffusely diseased and is amenable to angioplasty. Yeah, I don't think these things can be. Yeah, so I think we just end with the case. This is a patient, 57-year-old, diabetic, hypertensive, post-bypass, only 4 years ago. Complains of episodic chest pain, suggestive of ischemia after informed written consent taken up for angiography. This is his native vessel. You can see the external wires. So this is post-CABG. This is his LAD. There's competitive flow telling us that the Lima is patent, but diffusely diseased native LAD, but Lima is patent. This is his vein graft, which is going to either a distal vessel or LAD, I'm not sure. I think this is to LAD only. And you can see that this vein graft is degenerated over here, near its origin. And this is leading to distal vessel ischemia. So what we do in this is, we have wired this, and in this case, little pre-dilatation, not very aggressive pre-dilatation, a long stent to cover the entire lesion, and then we have a good flow down that graft. Okay, so this is an OM graft going to the back of the heart. This is a vein graft to a OM vessel, which was diffusely diseased causing ischemia, and this vein graft is instead. So I finished.
Can we have the lights, please?
Yeah.
Remote controls are little far.
Lights, please.
Highlight, please.
Dr. Chauhan?
Just give me 2 minutes.
Okay, I would like you to be here.
Yeah, I'm coming. I'm getting the lights on, sir.
For this to be a blockbuster CAV.
My hand is on the switch, sir. I'm just.
Come, sir, come. Come, Dr.
Sir.
Dr. Ramji is on the way.
Yeah.
He will be here in about another 10 minutes.
Yeah, 5 to 10 minutes.
Yeah, so
Yeah,
Dr.
please
Chauhan.
please
Okay. So, friends, what a masterly talk on PCI revascularization after CABG.
Sir deserves a big
So, Dr. Neeraj Bhalla, would you say the graft failure or the progression of the native CAD would probably be very challenging because these are very high risk patients. So, CTOs, severe calcifications, and what do you have to say about that? Severe calcifications,
So,
CTOs.
You're right, Dr. JPS. Once a vessel is bypassed, once there's a graft put, the native atherosclerotic process becomes accelerated. The disease in the native vessel becomes more and more aggressive. So, doing a vein graft or doing a native vessel angioplasty can be a very challenging scenario, especially in these patients who are now much older, who are sicker, who have got comorbidities. So, performing a angioplasty in a post-CABG patient needs to be planned out. You need to know what is your objective, and you need to have all the goods to deliver. So in calcified lesions, whether we need something to modify the plaques by rotablation or by intravascular lithotripsy, there are various techniques that we have. So planning is very important to achieve a successful result.
Great. So,
Sir, Dr. Ramji. Sir.
Dr. Ramji, sir, please come.
Hello, how are you? Hi.
Can we have a big hand for Dr. Ramji? हिजाब हटा दो सर.
Okay, so we were talking with Dr. Neeraj Bhalla. So would you say the CTOs would be the retrograde approach through the collaterals probably better? This is the latest. What do you say, Dr. Bhalla?
So chronic total occlusion is the most challenging coronary arteries to revascularize. There are three approaches. One is antegrade wire escalation, where we approach it with and persuade the lesion to be crossed by using wires of greater and greater stiffness and weight load. The second one is known as ADR, that is antegrade dissection and re-entry, where we go subintimally deliberately and we go across the lesion through the subintimal space, which is more softer than the actual vessel, which is totally occluded, and re-enter into the main vessel distally. And the third one is through retrograde through collaterals, again quite complex. But all these three technologies or techniques are used as and when required by the patients. So there are certain requirements for retrograde, collateral should be there should be a connection, so you should have certain requirements. And then the retrograde is also a very good option.
So, Dr. Bhalla, would you say probably when you have CTOs, probably this is the best approach, the retrograde approach, sir?
Yes, no. By successful, retrograde involves a lot more hardware, lot more time, radiation, chances of complications are low. So it is reserved for those 10-15% of patients whom you are unable to achieve success.
Great. So talking about the widowmakers, heart attacks, so it hits women as well. See, making them widowers.
Yes. Widower maker and widow maker.
Yeah.
Proximal LAD occlusions causing MI are called as widow makers or widower makers, and we have seen enough ladies or women with the same disease as men. Lesser percentage, but enough number not to be a rarity.
What about perforations seen in difficult to treat lesions? Why I said that was because Jack. See, last year published a case report of a 62-year-old male who had a CTO and PCI was done for the LAD and had a perforation which evolved into life-threatening cardiac hematoma, had a hemodynamic collapse with a blood pressure of just 60/40, with malignant arrhythmias, cardiac tamponade, and 5 coils, Dr. Ramji, were needed to seal the fissure, the perforated segments. So how common is the perforation seen, Dr. Bhalla?
So coronary perforation is one of the most deadly complications that every angioplaster fears. Every angioplaster who has had experience has caused and has had to deal with in an emergent situation. Because as soon as an epicardial artery ruptures, there is pulsatile flow into the pericardium, there is rapid development of tamponade, and the patient can collapse and die within a matter of minutes. So the reason for yes, of course. I mean, if you do a large number of angioplasty, you have to have. And the reason for that is there are 2-3 reasons. One is the perforation can occur from a wire, especially hydrophilic or slippery wires which go into very small vessels and they can cause rupture over there. Many times when we are treating a calcified occlusion or a block, we have to deploy the balloons under very high pressures. Now, high pressure, we deploy balloons at 12 atmospheres, 24 atmospheres. To give you an idea what is the atmosphere of pressure, your car tire is inflated to 2 atmospheres. You can imagine 24 atmospheres, what is the kind of pressure inside that balloon. If that balloon ruptures, there is a jet which can cause perforation or a major dissection. Oversized balloon. So there are various reasons, and you have to act very quickly by sealing the perforation, doing various things. One of the things that we do is we inflate a balloon immediately proximally so that it prevents the blood flow down. Second thing, we have these stents which are covered with material, with the fabric, which we deploy across the perforation, which causes the perforation to be sealed off. For very large perforations, coils can be done, but in the coronary artery, coils is not a very good idea because coils produce a complete cessation of flow and they act by producing thrombosis.
I will chip in here. I think to write a paper, I must congratulate them that they are writing this one. I mean, here the team approach, the heart team approach has to be understood. I mean, every one of us should know that these are the lesions where this can occur. These are the lesions which were discussed probably, and I believe that they had a good heart surgeon out there. And I think one should know where to say, now this is, I'm done. And now you take over. So as Dr. Bhalla said, if there is a perforation, which may happen, sometimes the wire is entangled. If that is not, you can put an occlusion balloon. Get care of the bleed. Put in the IVP, get the surgeon, they'll do the needful. You don't have to shove in coils and coils in the coronaries. I mean, then you will have malignant arrhythmia and 60 BP and all that. Right. So I don't think that's worth, and I would not understand why somebody would write a paper and accept it. Maybe this is the message that this should not be there.
Right.
So coils can be done in very distal vessel perforation, where you're losing that portion of myocardium is not causing a big cost to the patient. That's the only place where coils can be done, unless it's a life and death situation.
Sir, ask Dr. M.L. Bhalla to ask questions of the
Let me finish.
Sir, please.
Okay, so Dr. Bhalla and friends,
Question from the house.
the best treatment for acute heart attacks remains primary angioplasty. So Dr. Bhalla, transradial, femoral or brachial? Tell us, sir.
So all roads lead to Rome. You know, the idea is that the infarct artery must be opened as quickly as possible, as successfully as possible, and the flow restored as normally as possible. So this can be done. So this can be done by any of the routes that you're comfortable with. The data today is showing that radial angioplasty is probably a little safer as compared to femoral angioplasty. But there are many complex situations where femoral offers a more comforting route, a wider artery. Brachial angioplasty has been given up, either radial or femoral. So we are doing both the approaches in our centers. If the patient is relatively stable, we go for radial angioplasty. But if the patient is unstable, then a quicker and more safer way is to do that.
My last question, Dr. Neeraj, and also to Dr. Mehrotra. So Lancet, just 3 months back, November 2021, left main PCI and CABG. Mortality is similar. The choice remains complex and mortality at 5 years PCI 11.2% and CABG 10.2%. What do you say, sir? Both of you.
So the clinical trials that have been done, I showed you a slide about the comparative outcomes. It seems that mortality is one endpoint which does not differ between the two modalities.
Right.
But we have gone beyond mortality. We want to look at quality of life. We want to look at longevity without any. So in certain given situations, like I showed you in the guidelines, in triple vessel disease with diabetics, in left main disease with high complexity scores, CABG scores over angioplasty. In many of the areas, they are both quite similar. The Achilles heel of angioplasty remains the need for repeat procedures, which is at a higher rate than bypass surgery. But I think I spent 25-30 minutes showing you that bypass surgery is also not a panacea. So every treatment has to be individualized. And there are problems that can occur with both the procedures. I talked about, since the topic was bypass, angioplasty after bypass, so I showed you what are the scenarios in which bypass surgery patients might require angioplasty.
So the house is open to the questions, Dr. Kalra, for Dr. Neeraj Bhalla, and then we can have later on Dr. Ramji's talk.
If that is okay, I mean at 10:30.
No problem, sir.
Sir, you can just shorten the talk.
Sir, Dr. Tulsi,
Go ahead, sir.
I have also moderated many CMEs, but I was moderate, not like you. You were severe. Sir.
What is that?
सर ये एक लाइटर वेन में मैं सबको हंसाना चाहता था सर। आपने इतने सारे सवाल पूछ लिए, जब मैं मॉडरेट करता हूँ तो 2-4 सवाल पूछ के आगे पहुँचा देता हूँ सर, मेरे जैसे गरीब लोगों को बांट देता हूँ सर। Dr. Ramji has very rightly said, sir, it has to be a cardiac team approach, whether the given person, as we say, patient-centric approach, whether bypass or the angioplasty or whatever is needed, it has to be decided by the team, but what is the best? So we vouch for it, sir. So it's like a plumber deciding whether the pipeline has to be changed or some T to be given or elbow to be given. Sir, what do you mean about the very lighter? Sir, the venous graft and the arterial grafts, do they differ in their aftercare?
In the aftercare of the patient?
Aftercare, say, dual antiplatelet, the medical therapy, follow.
So,
Whether you have given a venous graft or arterial graft, will it matter in the aftercare in sense of the medicine and the follow-up?
So the evidence shows that for longevity of venous grafts especially, aggressive anti-atherosclerotic therapy is quite useful. Giving dual antiplatelets for a longer period of time is useful. Giving high dose statins is useful. Control of the other risk factors is quite useful. In arterial grafts, which are less amenable to the atherosclerotic process, these aggressive control of these factors may not pay that much of it. But you have got native artery disease, you have got extensive coronary artery disease anyway, which is why the patient is going for bypass. So these things should be done as a routine in post-bypass.
Sir, please clear my doubt. How far we are from an artificial conduit? Like we are now coming with the lab-grown milk, lab-grown meat, lab-grown blood, honey, and so many things. Are we likely to have an artificial conduit instead of artery or vein or whatever?
I think
Is that lab-grown food or honey or whatever, is that same as the natural one? No. So probably never the artificial conduits are going to match person's own conduits. Never, never, never.
So, since we have been having the tissue wells, so they are grown.
They also have limited life.
My last question is bare metal stents or DES. Do they differ in their follow-up?
not in their follow-up. BMS, I'll tell you one important thing for follow-up. As a cardiologist who's used BMS earlier in his career and now, BMSs create problems after 6 months of deployment. DESs create problems within 9 to 12 months of deployment if there is going to be a problem. So you should be aware that in case you have passed this threshold of 6 months with BMS, it's unlikely that there is going to be a problem. If you have crossed the threshold of 1 year with DES, it's unlikely that there is a problem. But otherwise there is no question.
Sir, thanks. I'm Dr. Vinodana. I'm a sexologist. Very simple
Sexologist.
question. Yeah. Sir, young patients come to us with erectile dysfunction.
Yes.
And there is an indication that if the patient is suffering from erectile dysfunction at the age of 30 or 35, he can be a patient of CAD.
Yes.
Is it true or not, sir?
So, you know that there are many causes of ED. If there is a vascular cause for ED, definitely it is a manifestation of diffuse atherosclerotic process elsewhere. We have seen they may coexist, or it may preempt coronary artery disease, or it may come later. So, there is definitely an association, but I think you know better. There has to be clearly a vascular cause, not one of the other causes of ED.
Another question, sir. Atorvastatin or rosuvastatin or all these stents which we are using, it has become a day-to-day routine of physicians to write them on and off. Patients come to us at an early age. For example, a patient 25 or 30 years with disease of obesity, he is having diabetes, he is having hypertension, and when he goes to a cardiologist, he definitely, when he finds that there is indication that he has to write statins, he writes it. And at the end of the day, when he comes to us, I being a sexologist, he's having erectile dysfunction, sexual dysfunction. What is the call? Because the patient who comes to you at the age of 25, 30, and if a patient comes to you at the age of 55 and 60. So my question is, sir, are you comfortable to use statins at an early age? Because these statins are creating erectile dysfunction, sexual dysfunction in the young patients.
So, we have many patients who come to us from Middle East and other who are 70 plus 75, who have got extensive atherosclerotic disease. They undergo bypass before they are discharged. Their question to Dr. Ramji is that when can I resume my activities? And it's a very important biological drive which is there in every human being, and at age 25 to be handicapped in this manner is a big problem. So I think the story cannot be generalized. We will have to understand what is the atherosclerotic burden at that age and stage, and there are very few cases in which there is a compelling indication to give high dose statins at that age. If statins are really the cause, then the other way to look at statin side effects and how to do it is, you can do 3 or 4 things. One is omit it and see if the problem goes away. If it does not go away, it is due to some other reason. If it goes away, you can reintroduce the same statin at a small dose and then incrementally, slowly increase the dose. Or you can introduce a different statin. These are the 3 ways in which, if there is a compelling indication, you make it happen.
Dr. Amish Vora has a question.
ये सारे out of syllabus questions हैं भाई लोग.
सर यहाँ पर ऐसे ही होता है.
I hope you are equal to the task.
Ramesh, yeah, go ahead. Sir, 2 questions. One, you spoke about proximal LAD, widow and widower. We have seen a lot of young deaths nowadays, probably post-COVID. Does the myocardial involvement in the proximal LAD territory is the cause? And second question, when you talked about, suppose assuming a patient after CABG, you have decided for angioplasty. Post-angioplasty, how many redo CABGs or how many redo angioplasty? Are there any trials based on that, sir?
Dr. Amish Vora is an oncologist, a very eminent oncologist, has his own Hope Oncology Center. Many of us are referring cases to him. He is a wonderful human being and an excellent oncologist.
He is also a wonderful questioner. So, post-COVID increased mortality. I think that is your first question. Now, no one knows why, what is the exact reason, but the reasons are manifold. Number 1 or 2 is, post-COVID, is there a proper cardiac evaluation that is done before people resume full activities? I think what has been seen is certain prominent people, very soon after they recovered from a severe COVID illness or relatively severe COVID illness, started vigorous physical activity and died suddenly. Whether this was due to massive pulmonary embolism, coronary artery thrombosis, not known. But we do know that inflammatory markers and thrombotic markers are significantly raised. All of us have done IL-6 and ferritin and D-dimer and all that. So it is prudent to not resume full-fledged competitive kind of physical activities for at least 3 months afterwards. We know that a certain amount of COVID patients have developed LV dysfunction, tachycardia, bradycardia. So until this thing abates, to resume vigorous physical activity is not a good idea. Third thing is that many, because of the long lockdown periods, most of the patients have not been able to come for regular follow-up. So whether they've developed new atherosclerotic lesions, they do not know. Many of our patients, old patients, have come in worse condition because they're coming after 1 year of follow-up, 2 years of follow-up lockdown case. So I think these are the 3-4 reasons that you have to think of.
So Delta and Omicron, both you are seeing or only Delta?
We are less in Omicron, but more in Delta, you are right. And your last question was?
Sir, post CABG, if you decide to do angioplasty,
so
what is the
post CABG, the commonest intervention post CABG is angioplasty.
Okay.
The commonest intervention post angioplasty is also angioplasty.
Okay.
All right. So post CABG to undergo redo CABG is not rare, but it is uncommon for various reasons. The grafts are used up, the vessels are not available, the patient is too sick. So, and we are really happy to offer a patient of post CABG, redo CABG, because it means that the patient has good graftable vessels and a good chance to improve. Dr. Ramji doesn't like it because he has to do redo CABG, but we like him to do it, but the opportunity does not present itself very well.
Dr. Mathur has a question.
Sir, my question is this, that after MI, most of the, after stroke and all, the cardiologists prefer to give very high dose of statins to the patient for a very long time.
Forever.
Yes.
Forever.
And that may cause cancer of prostate and all these complications. So I want to know for how long one should really give high dose of statins to the patients who has got stents or CABG.
Sir,
because the cancer is very common.
Sir,
First of all, this myth of statin versus cancer myth.
Sir, at least none of the clinical trials could show that there is increased incidence of cancer. If that was the case, and all the trials, the DSMBs, Data Safety Monitoring Board, this is always included as a point.
Dr. Amish probably has another question.
Sir is right. High dose statins and cancer, there are at least 15 trials. Not a single has associated with the two.
Yes, true.
So sir, ये आप निकाल दीजिए. But yes, we are apprehensive that there is that high doses of statins which can cause myopathies and all. How long to continue? So 2013 there was a guideline which came from ACCHA which said that there are 4 types of patients who you should give high dose statins and just keep giving it. Known ASCVD patients, LDL more than 190, diabetics, they said just give it. But this is not palatable to all of them. So now there are 2 things, that give high dose statins to reduce the LDL cholesterol by 50% and reach a particular level of LDL which is dependent on your risk. If you have got ACS, your LDL should be below 40. If you have multi-vessel coronary artery disease, your LDL should be below 55. If you have got any angioplasty procedure, MI, or you're at risk, your LDL level should be below 70. If you are at lower risk, your LDL level should be below 100. So there is a LDL target plus reduction of 50%.
I invite Dr. Mangla for a question. Get the mic.
It is little surprising, a patient who is all right suddenly lands up with an MI and he had nothing, say 15 days, 24 hours prior to that. Nice. And you do an angiography, you find a very tight lesion in the proximal LAD or mid LAD, and rest of the vessels are fine. Why so? Why a particular area of the coronary in one individual is involved?
Very true. And sometimes you just address that lesion and the person never develops any other lesion ever again in any other artery. It's a mystery.
And second thing is, the person who's a CABG, and he is all right, after a few years, develops some angina, some LV dysfunction, another stent. How many maximum number of stents have you placed inside?
The record for stents in a human being runs into high double digits.
Because I know a patient who has undergone 50 years of age, he had a CABG at Chennai. He is 80 now and he has already had 19 stents.
Yes.
And he is on his feet.
So, Dr. Chauhan,
so I'll just say like this last point, that the drug-eluting stents get endothelized, which means they are incorporated within the body within about 12 weeks time. So really, the struts are not there and they become incorporated usually within about.
So, Dr. Chauhan, I promised you mega blockbuster CME. Can we continue it for tomorrow as well?
No, no.
I'll chip in for your first one. You see, CAD is a heterogeneous disease. It's a heterogeneous disease. And many times, the MI is the first presentation. Why? You have soft plaque. You did TMT and all that. And there was nothing. And that's how, because of some precipitating factor, you had plaque rupture. And you had MI. You have chronic stable angina because you slowly are developing plaques. And when you have demand-supply ratio to an extent that you become too symptomatic, then you present. So probably that is a safer thing to present, and these are catastrophic events which happen. It's a very heterogeneous disease. That's why there are different presentations. And I would say that CT angiography probably has been one thing which has made screening possible even in patients who are high-risk population. So that if they have soft plaque, you can do pleiotropic medicines, lifestyle changes and all that, so that they may have less chances of presenting with catastrophic events in the emergency.
Just
cardiac surgeon is very fond of CT angiography. No, and cardiologist dislikes CT angiography.
That's right. But what I'm saying,
it's an excellent. No, I'm saying this because Dr. Devi Shetty some months back, after somebody had also commented that everyone should get a CT angiography, which is not correct. But Dr. Ramji,
I said high-risk population.
Absolutely right.
Just one
it is a wonderful screening tool to look at the risk or the actual burden of the disease that is.
Objective.
I always felt, whenever you order a CT angiography, and if there is a doubt, you again end up with a proper angiography, so the patient has to receive the contrast two times.
No, but you're not ordering in a symptomatic or so-called where you have suspicion.
Sir, I was just saying one point.
You are ordering that in a risk profiling in a high-risk population. Suppose my mom and my father had this. I'm a smoker, I'm diabetic. I'm a high-risk population person. So I should get this even if I had a stress test negative.
These patients are diabetics, they have compromised kidneys, they land up with a lot of problems.
That's right.
I think contrasting should be kept in mind.
Yeah, in those cases, definitely.
And most of them are. Just one thing, you see, how much to investigate? A 70-year-old guy just gives a history. जब मैं बहुत तेज चलता हूँ, मेरे को थोड़ा सा यहाँ दर्द होता है, और थोड़ा बैठने से ठीक हो जाता है, उसका TMT भी ठीक है, उसका echo भी ठीक है, उसका stress thallium भी ठीक है. But the cardiologist did not ignore his symptom and did a coronary CT angiography and did a proper angiography. He had a triple vessel disease.
Sir, if the patient is diabetic, the likelihood of this person having high burden of disease with minimal symptoms and minimal signs is quite high. So, in a diabetic patient whose the disease burden is so extensive that we are surprised every day. And minimal symptoms, minimal positivity on non-invasive testing, still the disease burden.
Friends, I think now it's time for Dr. Ramji Mehrotra's showstopper show. He was supposed to be opening the innings. He happens to be the pinch hitter. Anyway, we give him 15 minutes to wind it up. I'm sorry, sir, to set that deadline because people will lose patience otherwise. Just 1 minute. I would just come here, Nitish. Can you give that Dr. Mangla sir? Kindly felicitate Dr. Ramji Mehrotra sir. Big hand for Dr. Ramji Mehrotra. Total arterial grafts man. And sir, stay, Dr. Mangala, stay. Just a small cup when he takes his coffee in the morning, physicians forum of India. You will remember it.
Coffee पहुंचाते जाएंगे आपको.
And you will remember all your other dance when you take this directory. And I would request you, Dr. Mangala sir, to hand it over to Dr. Neeraj Bhalla also.
Thank you. This is your member directory.
Yeah, the members directory. Yes. Over to Dr. JPS Tulsi sir to introduce Dr. Ramji Mehrotra. 15 minutes for the talk. I assure you, just 15 minutes. And we are just done with the question answer session. We head straight to the dinner section after this. So give 15 minutes to Dr. Mehrotra. He was stuck up in a case. He was trying to save a life. So big hand for Dr. Mehrotra, sir. Over to you, sir.
So, friends, finally we have Dr. Ramji Mehrotra with us. Dr. Mehrotra, do you remember us?
Yeah, why not? Yeah, please.
So, Dr. Mehrotra has been everywhere. Apollo, Fortis, Scots, we referred so many patients to him, but then again he moved on and forgot us. What do you say? Madam Ramji, you forgot us?
No, never.
He says never. Okay, so Dr. Ramji is of cardiothoracic and vascular surgery, CTVS, and has joined BLK Max Center. Vast experience of more than 26 years in beating heart surgery, total arterial CABG, which is going to talk about today. And request Dr. Mehrotra to go ahead with this talk.
Thank you, sir. And I don't have words to say that at 10:15, 10:30, you have still years for me. I'm sorry, and I must apologize that I couldn't make it in time. I was stuck up with one popliteal artery injury while they were doing a knee replacement. So, yeah. So CABG is one thing which changed the outlook of CABG.
Sir, we can't hear you at the back.
So,
Yeah, it's fine.
so it became at one time more operations done in world than gallbladder surgery, and it increased survival benefit, gave survival benefit, and over the time, all the improvements in allied branches have increased the outcome, have decreased mortality. Nowadays our focus is how to decrease morbidity and provide longer term benefit to the patients. I will walk you through the CABG, how it evolved from vein grafts to one artery and the vein, more and more arterial conduits to total arterial revascularization, especially using bilateral IMAs, internal memory arteries, and why they are so good and their long-term results. So CABG is only the definitive treatment of CAD. It gives the best symptom relief, provides best survival benefit and event-free survival benefit. This is the first time the surgical community has not stood by ACC guidelines on PCI. There is a whole lot of debate going on, but we believe that surgical results are sine qua non, have not been matched with any stents or any medical treatment in some subsets. And for us, any distal left main, any proximal LAD, single or with double vessel disease or triple vessel disease in diabetic, or with mechanical complications of CAD like alveolism, mitral regurgitation, you have the CABG, which is beta and class 1 indication. How it is done? Conduits are taken from elsewhere in the body, the vein grafts from the leg. This is how this was started with. Or you take artery. The main artery is internal mammary artery, either one or two. Sometimes you have to use the radial artery from non-dominant or dominant hand even, and some other arteries in redo cases nowadays that is required. So this is left
internal mammary artery going to the left anterior descending after the block. These are called the pedicle grafts, all live grafts, and the previous one was free grafts because you have to take that away from the original site and you have to hook one end to the aorta and the other end to the coronary artery beyond the blockage. This is a rare slide which shows how the vein grafts run down as the time passes. The same patient. You may not be able to appreciate, but I will make you believe that this is the internal mammary artery going to the LAD. And after 11 years, you see how strongly going that is. It is continuing to supply the septals. So this is the difference. The arterial grafts continue to provide blood flow to the coronary artery, and they don't run down with time. This was the seminal paper from Cleveland Clinic, which showed that internal mammary artery continues as years pass by when grafts go down. And this changed the whole lot understanding about the quality of the grafts. And sooner this was found out. We all know that left anterior descending artery supplies 2/3 of the myocardium of the LV. And giving arterial grafts which are longer lasting on this artery gave survival advantage so much to the patients that other arteries blocks, if they were covered with vein grafts, they gave symptom relief even after 8-9 years, and patients continued to survive even if they had recurrent angina, recurrent events, but the survival benefit was continued because of this artery. So the thought process began that more arterial grafts should be better, and that is how the surgeons started doing. And the theory was why the arterial grafts are better, because these are live grafts. These are some of the things which make arterial grafts survive longer. So these are some of the arteries which have been used, but nowadays most of the cases we are able to do using bilateral mammary artery in many ways, and these are some of the combinations, permutations you can have. This is the radial artery as a free graft, this is a pedicle, lima. This is the lima as a free graft, radial as a free graft to OM, and pedicle lima. You can have a crossover, that right artery is going to the LAD, the left artery is going to the posterior grafts. This is what we call as composite graft. Here you can appreciate the right internal mammary artery has been cut away, has been used as a free graft, and has been hooked to the side of the lima, and a Y has been created. And by using what we call as sequential grafting or jump grafting, 3, 4, 5, 6 grafts can be done using this composite grafts. And this has been shown to provide the best possible outcome, ensuring the total arterial revascularization and longer lasting. This is the intraoperative photo. And these are some of the cases which we have done. Even acute marginal or the acute margin of the heart, you can reach. So this artery has been able to touch down multiple PDA, PLV, acute marginal. So all those areas are accessible. How is that possible? I call bilateral internal mammary artery, or BIMA in short, and it's really Jivan BIMA for them. It is associated with better short and long term, and it provides incremental, incremental. The time passes, vein grafts go down, but this with time increases the benefit, the incremental benefit with time, and associated with fewer drawbacks. And it has been done from 60s, but still, it's not in vogue, it's not very common. Why? It's not user-friendly operation, or any operation is not user-friendly from that way. One has to learn, one has to be perseverant about any operation. One has to learn the trick and do that multiple times and negotiate the learning curve. This is a difficult operation, definitely, and that's why very less people, total 5 to 8% surgeons all over the world do this day in, day out. This is definitely technically more demanding, little more time consuming. External issues are not much common, because I would say that external problems, even in single graft or even venous graft CABG, are different from 1% to 14%. And this is where the art of surgery comes in. If we have a lot of collateral damage from external perforators of lima and rima, you have collateral blood supply damage to the sternum, and then you have complication. If you are very low on cautery, if you are taking care of the perforators, decreasing the collateral damage, the alternate blood supply to the sternum is maintained, even in diabetics who have endoarterial problems, and the sternal complications are less. Why bilateral internal mammary artery or internal mammary artery is the best graft? Because it is a different artery as compared to any other peripheral artery. It has intact internal elastic lamina. It is more elastic fibers in the media than muscular fibers. It is very thin wall. So internal diameter, we all know that blood flow through the pipe is 3 to the power radius. Even a small increase in radius has exponential increase in flow through that tube. So if you have very small vessels, the internal and external diameter are almost same. So 2 millimeter artery has almost 1.8 millimeter lumen. Radial artery doesn't come that way, it has higher muscular. And
probably like to finish and have questions.
Okay, so this has less side effects of luminal problems causing intimal or hyperplasia in the media, and that is why it is resistant to atherosclerosis. Lima and rima are resistant to atherosclerosis. Plus, I call them drug-eluting condones. How? The intima supplies more endothelial relaxant, including nitric oxide and prostacyclin, and it protects the distal bed from atherosclerosis. We all know that atherosclerosis process is an inflammatory process. That's why it is high in diabetics. It has the preventive aspect, and that's why the coronary artery bypass with arterial grafts protects the distal bed. You can imagine how much that is beneficial in diabetics. So this property of internal mammary artery ensures excellent graft patency, ensures relief of symptoms, and many studies have proven that. And especially in diabetics, renal problem patients, women, the patients with renal and LV dysfunction, these subsets have bad results. Even in those cases, this provides better results. And it prevents reintervention by stents or by redo CABG. So this is really a bima for longer term, and it is safe. Beating heart surgery helps do the complete revascularization, because beating heart helps those small coronary arteries which are full to be seen and grafted. In quiescent heart on heart-lung machine, these arteries look like capillary, and some surgeons would leave that. The West has different literature. They say that beating heart surgery should not be done. But as again I said, you have to do that to negotiate the curve and then find the benefit and provide it for the patients. The beating heart surgery is possible even to take out the endarterectomy specimens. We have taken the stents out. You were saying 19 stents. We have operated on a patient who had 10 stents in him, and we had to remove this. And his ejection fraction also improved from 20%. He was already condemned. But now he has almost normal ejection fraction and symptom relief. So these are also possible. But we will not do, in certain cases, in high demand situations, acute myocardiogenic shock and severe MR and all that. So these are some of the limitations. These are some of the cases where you see the post-op angiograms. And these are some of the other things which patients appreciate. They don't have a cut in the hand and leg. Their morbidity is less. They can walk faster. They can recover earlier. They join the work early. And then these are the things which hospital also loves. So with this, I would say some words about these combination medicines. These are the guys who have sponsored today's program. And I think you guys are writing the antiplatelet and statins to them. So thanks to
I hope I'm able to give you some of the message that the arterial graft is the thing which we look at.
Can we have the lights,
much
please?
better than the venous grafts.
आपका बहुत हो गया भाई
Lord Johan, probably intervene, otherwise we'll continue this till Friday.
Sir, just a few questions from you and Dr. Bhalla, and we'll wind it up.
Okay, so what a great talk, friends, from Dr. Ramji Mehrotra. So it's total arterial CABG, Buddha, is now the leading trend in CABG for coronary artery disease, as it allows higher degree of versatility, higher patency, and probably minimal, if any, interventions. What do you say, sir?
Yeah.
Okay.
Longer event-free survival too.
Wonderful. So the AHA flagship journal Circulation, September 2021, talked about the modified surgical technique, the no-touch technique. Dr. Khudar would know about that. So subcutaneous vein grafting, when used, probably less likely to get blocked with the no-touch technique. What do you say, sir?
Yes.
Okay.
But still, even if you compare with no-touch technique vein grafts, and you compare the arterial grafts, especially
no match.
the IMA, there's no match. We have
Absolutely.
70% better survival.
Sir, I'd like to draw your attention. Dr. LMP is there. Dr. LMP? Like to have your attention. So the new December 2021 coronary revascularization guidelines by ACC,
सर जी एक बात
AHA,
बताऊं आपको, आप सवाल जितना मर्जी अच्छा पूछो, लेकिन ललित को ना कभी आते हुए मत टोकना चाहिए।
okay.
Sir, I know it because I have stayed with him in second and third prop in Maulana Zad. ठीक है? This is one thing he doesn't like.
He doesn't like
To be disturbed when he's
while he's eating.
Sir, he is not worried about vein graft.
आपको मूवी देखनी पड़ेगी गदर
He is not worried about anything, but he is worried if you disturb him while eating.
गदर हो जाएगा
Okay, sir, the ACC AHA are spurring controversies. The American Association of Thoracic Surgeons and the Society of Thoracic Surgeons, Katbuda, have withdrawn their support. The ACC-AHA have said the guidelines have gone through extensive peer reviews and we are not going to back down. The surgeons denied. They
I
said
had given
no.
the hint in the start of my talk, but I don't think we want to go there. And
Let me
there are
complete.
enough reasons that the guidelines have not been supported by surgery.
Let me complete, sir. So the main objective or the objections in the downgrading of CABG surgery from class 1 to a week 2B recommendations to improve survival in patients of TVD with normal ejection fractions. Dr. Tulsi? And a class 2A in TVD with mild to moderate LV dysfunctions. Also objections for treating PCI and CABG. Dr. Neeraj Bhalla, sir?
No, I'm here.
Okay, sir. Where are you?
Here.
Okay. So, Dr. Bhalla, so also objections to treating PCI and CABG as equal 2B recommendations in TVD for survival. And also concerns for class 1 recommendations for radial conduit, as this is higher than the bilateral memories. So, what do you have to talk about that? The Lima, they said 1B recommendations, RIMA, a 2A. A lot of studies showing that if you use the radial artery grafting, probably incorrectly, there are worse outcomes. So, any concerns, Dr. Ramji, about the graft spasm and hypoperfusion in radial artery grafting, sir?
You see, we have to understand, as a surgeon who will simplify things to be understood, I have the understanding of coronary artery disease that number one, this is very heterogeneous. So scientific studies also have to be based that there is no bias. We have to understand that. And bias is very difficult to take away. So heterogeneous disease makes sure that there are inherent biases involved. Okay? So, to understand from previous studies, if you have normal LV and if you don't have proximal ostial LAD, you don't have diabetes. OMT, PCI, CABG, at least up to 6-7 years are almost same. But if you have LV dysfunction, if you have diabetes, if you have osteoproximal LAD, along with whatever combinations you may have, or distal left main, the surgery has been shown to be better. In many head-on studies, PCI and CBG, this benefit was not achievable by PCI. Radial artery is a muscular graft, is a thick wall graft, is very vasospasmic graft. You have to understand that this is not a user-friendly conduit. If you have blockage which is less than 70-75%, and you graft radial, it may backfire because it doesn't withstand the competition. Lima or Rima, they are more rich in elastic fibers. They have less muscular fiber, I was alluding to. Their physical property is different. They withstand competition better than radial artery. But if you follow vein grafts, radial graft, bilateral mammary, up to 7-8 years, you're not going to find a perceivable difference, especially if we have the sample size which is very small. We have to understand, if you have used Lima to LAD, which supplies 2/3 of the myocardium of the LV, you have achieved survival benefit, maybe up to 80% or so, long lasting. So to find out advantage of any other arterial graft, whatever that is, radial or mammary, the different, you have to follow 12+ years. And these studies which have shown survival benefit by using right internal mammary artery along with left are beyond 15-year follow-up. And they have shown incremental benefit, mind you. What is incremental benefit with time? So the time period also has to be greater than 5 years. You have to follow them, and it's mostly not possible. People ask me, Ramji, why would you do bilateral mammary in an 80-year-old guy? Tell me. They have that very different vision on what the treatment should be like. In an 80-year-old person, you have atheromatous aorta. His radial artery most likely will be atheromatous. You have a cut in the leg. They have bilateral knee problem or hip problem, whatever. He will probably not be able to walk as much as he used to. Before was that because of the angina, now just because of the leg problem, include problem. If you do this bilateral mammary composite grafting, you have used arteries, okay? You have not touched the aorta. The severe risk probably is only limited to intermittent AFib or AFib. You probably are not clamping the aorta. So those, and morbidity less, they can walk, they can be better. So these are some of the advantages which also come hand in hand, and somebody has to realize that why 80-year-old person also has or can have this kind of operation. Yeah. I hope I'm able to
So, Dr. Neeraj Bhalla, so the latest ACC AHA guidelines no longer valid? The latest guidelines, Dr. Bhalla?
valid है हमारे
No, आपकी valid नहीं, इनकी valid है. बोलो sir.
Sir, this is a controversial topic.
Very controversial.
I think a controversial topic or another.
Drawn into.
Yes, I think
I think the treatments are, therapies are complementary and not competitive.
Exactly.
And as we keep on learning as things go, both the techniques and technologies are evolving. Let it be like that.
Well said, sir. Dr. Moda has a question.
So, Dr. Ramji, I think take-home message is arterial grafts are in general better than venous grafts. And in arterial graft, memory artery grafts are definitely better than radial artery grafts. Is it right?
Yeah.
So, my question is, technically, Lima or Bima, is it more technically demanding than radial artery graft?
Yes, definitely yes. And that's why only 5 to 8% surgeons world over use this. But overall, if I can learn, everybody can learn. So this is, I think it is angioplasty, I think in everywhere. I mean, it's in practicing medicine also. You have to learn, negotiate it. And it is perseverance and belief in a thing. Of course, objective data are available. So that you negotiate that in your cover and you surmount the problems and you offer to the patient. Vein grafts are easy to harvest, they're very easy to do. They have given survival benefit up to 8-9 years, and along with one Lima, they are still probably so-called gold standard. And that's how that is very common operation.
Bima is most difficult to do. Bima.
To me, I would say no.
Not to you. Average. How many cardiac surgeons are doing Bima?
5% to bataya world.
5%. So thank you. Dr. Gardner.
Sir, yeah. Just to end up my last query, I want to clear my doubt for my friends. High dose statin is given, not to lower the cholesterol, basically for pleiotropic effect and anti-inflammatory. So do we plan or do we think that the inflammation goes lifelong? I think even Ukraine and Russia war will end someday. So does the inflammation go endlessly? So should we use the high dose statin endlessly, or will we have some parameters to step down? Because there should be some achievement, some targets once the Kyiv or Kharkiv or whatever they have achieved.
See, luckily I am the surgeon and I don't use much brain, and I send the patient back to Neeraj Bhalla so that he can use and have all academics.
I have already answered that question.
Sir, question is still burning, like Kharkiv. Let Dr. Tulsi say about what is it?
Ongoing inflammatory process.
So it is forever.
And arterial grafts calm them down. They have drug-eluting effect and protect the distal bed from inflammation. So remember Ramji, remember arterial grafts where you want less inflammation.
So you want to say once a liar is always a liar? Once a liar is always a liar. So एक बार inflammation हो गया तो हो गया. तो सारी उम्र थोड़ा चलता रहेगा सर? नहीं सर. Please give me the answer. कभी तो कम करना. हाँ फैसला करके जाना.
Sir, statins का role is not anti-inflammatory. It is to reduce the LDL. The LDL burden, there is a global cumulative LDL burden. When it crosses a threshold, that's when disease process is supposed to occur. By lowering your LDL, you are reducing the total LDL burden. It's not. One of the actions is that it is anti-inflammatory. The main thing is it is reducing LDL burden, which is the major risk factor for atherosclerosis, along with the other factors that are diabetes, hypertension, smoking, and other things. Inflammation, this is a mythical thing which we really do not know much about. There is only one clinical trial, that is Jupiter trial, which HSCRP was measured and found to be reduced by statins. That's also a flawed trial. Paul Ridker has come under a lot of flack after that. Inflammation equals statins is not a valid concept.
Forget about anti-inflammatory.
Look at the LDL, that's a measurable feature.
Friends, all good things have come to an end. What pleases me is that we could finally get Dr. Ramji Mehrotra also to chip in. He was busy with his patients, and we thought that he might just be able to come and show up, and we could introduce him, but actually he could give his deliberation and you could ask questions and answers. So that's a wonderful thing. I think we had a wonderful session moderated by a wonderful chairperson, Dr. JPS Tulsi. A deliberation delivered by two wonderful speakers, Dr. Neeraj Bhalla, an old friend, and Dr. Ramji Mehrotra, an absolute revelation to our group. Sir, my just one question. When you use total arterial grafts, does it cost more to the patient as opposed to a conventional graft?
It should cost more, but I have not been able to do that. It should. I mean, if you are putting in efforts, if you are doing that, some of the paraphernalia used are also different. We use cell savers to transfuse the same blood to them, have less morbid causing autologous or homologous blood transfusion. So it should cost, but we have around say 40,000-50,000 difference only. So at this point in time, this is like that.
Sir, if I have a patient with ejection fraction of 50% and I send him to you with triple vessel disease,